The Global Surgery Lab presents the pericardiocentesis procedure. The goals of this video are to identify indications and contraindications for pericardiocentesis, to demonstrate an approach to performing pericardiocentesis, and to outline complications and key principles of post-procedure management. Indications for pericardiocentesis include cardiac tamponade, hemodynamic collapse, and when emergent removal of fluid from the pericardial sac is required to maintain cardiac output. There are no absolute contraindications for emergent pericardiocentesis. Pericardiocentesis needs to be performed for hemodynamically significant effusions and when signs of cardiac tamponade are present. These include tachycardia, hypotension, pulsus paradoxus, jugular venous distension, and decreased heart sounds. The general approach to pericardiocentesis includes 1, to landmark the xiphoid process and costal margin, 2, to introduce the needle 2 centimeters inferior to the xipho-costal angle, 3, to proceed at 30 degrees, 4, to aspirate during needle advancement, and 5, to remove the needle once no more fluid can be aspirated. The following equipment will be needed: appropriate personal protective equipment, including sterile gloves, antiseptic skin cleansers such as chlorhexidine, large gauge needles with trocar removed, 20 or 21 gauge needles are acceptable in a child, 18 or 19 gauge needles are acceptable for an adult. It is helpful to have both a small 5 to 10 ml syringe and a large 20, 30, or 60 ml syringe, 3-way stopcock and angiocatheter with extension tubing, and emergency resuscitation medication and equipment. If available, an ultrasound must be used, as well as cardiac monitoring devices. To begin, collect the supplies and position the patient supine, with the head of the bed raised 30 to 45 degrees. Palpate the xiphoid process medially and the last thoracic ribs laterally, which form a triangular space. Sterilize the skin and create a sterile environment. Once the area is prepped, freeze the skin overlying the needle entry site with 1 to 2% lidocaine. Connect the syringe to the needle gently so that it can be easily removed without disrupting the needle position. A large bore 20 gauge or larger needle of sufficient length is then inserted into the subxiphoid region, 1 to 2 centimeters below the xiphoid process and between the inferior costal margin. Angle the needle under the ribcage no more than 20 to 30 degrees to the patient's skin and aim the needle towards the patient's left shoulder as you continuously aspirate the syringe. Short, quick jabs, as opposed to slowly advancing the needle, is required to penetrate the parietal pericardium and to not tent it against the visceral pericardium. Advance the needle until the fluid, blood, or air is obtained. It's important to note that air could indicate injury to the lung, such as a pneumothorax. The distance from the skin to the pericardium is based on body habitus. If no fluid is obtained, withdraw the needle to just under the skin and angle the needle more posteriorly, closer to 30 degrees, and re-advance the needle while continuously aspirating. Remove and flush the needle after several failed passes. If ultrasound is available, confirm the needle is in the pericardial space and not in the heart with an apical 4-chamber view. Secure the needle at the skin to make sure it does not move, and change to a large syringe and continue to remove the fluid. Complications of pericardiocentesis include cardiac arrhythmias, pneumothorax, accidental puncture of the heart or coronary vessels, or injury to the stomach, liver, or diaphragm. Post-procedure, it's important to monitor for changes in hemodynamics. It is also important to obtain an echocardiogram if available once spontaneous circulation is achieved. Finally, document the pericardial fluid removed and send the fluid for analysis, including cell count, protein, and culture as indicated. In conclusion, pericardiocentesis is a life-saving procedure for the treatment of large pericardial effusions and cardiac tamponade.